am here today with Dr. Mirella Dapretto and Dr. Shafali Jeste from UCLA, and we're going to be talking about autism today. And before we get started, I would actually love to just do a quick poll. If there's a poll should have popped up on your screen. If you could tell us if you're a Nanit user and if you're currently expecting or not, that would be fantastic. So if you wanted to do that while we get started, that would be great. So I would love to start with you, Dr. Jeste, and I would love for you to tell us a little bit about autism, and then we will move on to talk to Dr. Dapretto, who's going to be talking to us a little bit about her research and some of her most recent findings, perhaps, and studies that she has planned. So I will pass it over to you, Dr. Jeste.
Sounds good. And thank you to you and Natalie and your team for inviting us. And for all of you who are joining, it's so much fun to see folks from all over the country and different world, actually, in different time zones joining us. With COVID, we've actually been able to do this kind of outreach work, I think, much more effectively with Zoom. I know we're all tired of Zoom, but at the same time, I think it is a great vehicle for us to actually be able to connect with each other and talk and learn from each other. So thanks for listening to us. So what I'm going to do is I have some slides, and I'm not going to try to make them too didactic or too technical, but I'm going to give you kind of a basic overview about autism and early signs, and kind of give you a framework for why we like to study early development in autism. And then that'll kind of segue nicely into Dr. Dapretto talking a little bit more informally just about the research that we've been doing and how we're actually partnering with Nanit specifically. And then we're happy to take questions. I'm not going to talk for more than 20 minutes. And just to give you a background on me, I'm actually a child neurologist by training, so I'm a clinician. I do take care of kids with autism and other neurodevelopmental disorders, some early diagnoses, some late diagnoses, some helping parents figure out what the right diagnosis is, and then of course what the right treatments might be. Sleep issues are something we see a lot actually in kids with autism. It doesn't mean that if you have a sleep issue, you have autism, but just that sleep issues can be pretty challenging for some of these families. So I do actually take care of a lot of kids who have primary sleep issues. I'll show you like a slide or two about that at the end. But again, I think many of you are probably not in that place at all, but just to know that there are some overlaps between some of the things that Nanit is working on and what we're doing clinically and in research in autism.
Fantastic. Dr. Jeste, I'm just going to interrupt you just for a second. I see a lot more people joining, and so I just wanted to, to reintroduce you both. Yeah. I am here today with Dr. Shafali Jeste and Dr. Mirella Dapretto from UCLA, and we're going to be talking about autism today. And my name is Dr. Natalie Barnett, and I'm the Director of Clinical Research here at Nanit. We're really excited that you could join us. If you wanted to tell us where you're from in the chat, that would be great. And then you are more than welcome to put your, if you have any questions for Dr. Jeste and Dr. Dapretto at the end of the session, you can put those in the Q&A section of the screen down at the bottom left, bottom right of the screen. So back over to you, Dr. Jeste.
Yeah. Okay. Great. Thank you. And so. Yeah, let's get started. So we're going to talk just very briefly about autism and kind of more generally how we think about it clinically first. Autism is one of many what we call neurodevelopmental disorders. And these are, as we'll talk about in a minute, conditions that we diagnose based on behaviors and developmental features. We have this textbook that we as clinicians use called the DSM, the Diagnostic and Statistical Manual. And that actually just lists out all the symptoms that we, that might, help us as clinicians make a diagnosis of various neurobehavioral, neuropsychiatric conditions. So the neurodevelopmental disorders chapter includes autism. It also includes intellectual disability, global delay, ADHD, social communication disorder. So there's a bunch of these different conditions that we diagnose, autism being one of them. But there's some key themes that you kind of need to know before we talk about what autism is that a lot of those conditions overlap. So it's not that if a child has global developmental delay, we can't make an autism diagnosis, or vice versa. So we can certainly make multiple diagnoses together, and we often do. It's just a question I get asked a lot. Another really important point is that these are diagnoses based on a list of symptoms or things that we as clinicians might pick up or a parent or caregiver might pick up. It's not based on biological data or blood tests or other kind of more maybe even objective measures that we might use to diagnose other kinds of medical or even sometimes psychiatric conditions. Along those lines, it's not a diagnosis based on cause, right? And we know that there's lots of different causes or pathways to getting to having an autism diagnosis. And I'm not going to get into that today, but just to say that we know that genetics accounts for a proportion of kids who have an autism diagnosis, not 100%, but we know that there's a lot of probably factors that we can't even measure yet, right? So, but again, we're making this diagnosis based on a list of behaviors. And as you can imagine, because of the fact that it's based on a list of behaviors, there's a huge range of symptoms and signs that we see. In our scientific world, we talk about it as heterogeneity, meaning that there's just a lot of variability in how kids with autism present. That's true not just in terms of when they're diagnosed, but also what their trajectories look like. It also affects what kinds of treatments might work for them, what kinds of co-occurring conditions they might have, like sleep issues or GI issues or other things. So, it's a pretty variable group of kids. And so it's hard to generalize and say, oh, if this is happening in this child with autism, it's happening in that child. And again, I think that's really important, especially if you are a parent of a child with autism or know kids with autism. You might, think, you might sort of know one child and think, oh, well, this should generalize to everyone. And it doesn't always. As you can imagine, for clinicians, that actually makes it kind of hard because it's hard for us to give a hard and fast rule or a predictor for parents. Parents always ask me, what is the likelihood that my child's going to have certain developmental outcomes later? And we don't have actually great ways to predict that. That's actually part of what we do research in, is to get more precise in those kinds of discussions, but we're not quite there yet. Okay, so let's talk about what's required for an autism diagnosis. And I've pulled this out of the DSM, so I apologize in advance for some of the verbiage. We use words like deficit and disorder. It doesn't mean that kids with autism can't have strengths. And many of our kids with autism have lots of strengths and beautiful areas of skill that we leverage actually, but that as clinicians, we're talking about deficits and disorders because we're thinking about the areas that we might want to help improve, to help overall outcomes. But autism is based on having symptoms in two main areas. So it is defined by having challenges in social communication skills, and we'll talk about that in a minute, and also having challenges in the presence of repetitive behaviors or really fixated or restricted interests. So let me give you even more detail around that. So, and this is straight out of the DSM, right? So for social communication impairment, the 3 criteria, and a child has to meet all of these, is that they have deficits in kind of the back and forth of social interaction. So social emotional reciprocity. Deficits in nonverbal communicative behaviors. And I'm going to show you a couple of videos as examples, but these are things like eye contact, gesturing, being able to use, I'm doing it now, right? So even though I'm on Zoom, so how do you use, how do you communicate with others, not just with language, but in other ways. And then the last one is deficits in developing, maintaining, and understanding relationships. So social relationships are challenged. And again, a child has to meet all those criteria to meet criteria for autism. In the other domain, there's 4 criteria. You actually only have to meet 3 of the 4, and it can be any 3 of the 4. And so you can see the list here. So the first is having repetitive motor movements. So kids will have hand flapping or have other motor mannerisms that are pretty stereotyped. I want to make a really important point that a lot of typically developing kids have repetitive motor mannerisms. So you have to remember these have to be in the context of all these other symptoms we're talking about. The second is insisting on sameness. So being really inflexible with regards to changes. Kids struggle with routines being changed, and it actually leads to a lot of difficulties, and parents often have to stick to the schedule. Otherwise it causes a lot of distress, not just for the child, but for the family. Highly fixated interests that are abnormal in intensity or focus. So, we all have things we're more interested in, but if it gets in the way of being able to learn about other new information or engage with new experiences, that's when it's a problem. And then the last one, which is something that actually Dr. Dapretto's group does a lot of research in, and it's new in our newest DSM, is sensory issues. So children might have hyper or hypo, so over or under responsiveness to sensory inputs. That can be sound, that can be taste, that can be texture. Sound and visual stimuli are probably the most common, but kids often tend to be really hypersensitive to certain inputs, and that can also get in the way of the way they function. So one example is I have patients who say, I can't take my child to the mall because or to a store because it's so loud that they just become so extremely distressed that we have to stay home, right? Because that loud sensory input is just overwhelming. So that's the last sort of criteria there. So those are the criteria, but again, imagine how different those things can look based on the age of the child, or again, the environment they're in, or their co-occurring conditions. So you might ask, well, how do we make this diagnosis, right? And so it's based actually both on history that a parent gives us, as well as the way a child appears in the current state. So I bring that up because sometimes I see kids in clinic who are already school age, and I do want to kind of understand, when did these things develop? What did the child look like early on? That history I'm getting from the caregiver, but then I'm also going to directly get some information based on how the child looks in that moment. So we're going to rely on report, but we're also going to do some direct assessments. And I don't have time today to go into what kinds of assessments we use, but there are some standardized, really well-developed tools that help us kind of pull out some of those things that I described in the DSM, like social emotional reciprocity or even repetitive behaviors. So I'm going to show you two examples of nonverbal communication skills, or what we call social communication skills, just to show you the difference between children who have an autism diagnosis versus the ones that don't. These could be subtle, right? Now, we as clinicians pick them up very quickly because we're kind of attuned to it. And I would say parents are pretty good about picking this up too. You know your child the best, but sometimes these can be subtle. So I just want to show you some examples. I hope this plays. So this is an example of a typical 16-month-old.
You see the bird up there? That's the parrot. Pretty neat, huh? Which book do you want? Jim. Bird!
So what you see there is the examiner pointed at something out in the environment, and that actually that pointing and sort of trying to elicit a joint response with the child is called joint attention, right? So what joint attention is basically two people engaging in something together in their environment, essentially. It's a triadic interaction. And so this baby did this really beautifully, right? He followed the point, and then he actually pointed himself and kind of squealed with delight. And you can imagine that's a beautiful interaction that actually allows kids to learn a lot. Think about when many of you are parents of babies, like you're out in the world with your baby, they're in the stroller, and you see something, you say, oh, look, there's a bird or something out in the environment. If the baby looks and hears you say that, that's how they actually start to learn language. And actually Dr. Dapretto's group and many others have really studied this, this really important basic construct of social communication development. And it's really important for language development and other skills. So this is the same press or bid that's being done by the examiner, but this is in a child who was eventually diagnosed with autism, didn't have an active diagnosis at this young age.
Look over here. Oh, you're gonna look at my finger? You like that? And look, see the duck? It goes quack, quack, quack. And somebody else do that the other day too.
So you see here, and again, I'm showing you kind of an extreme example just to make a point, but here this child, what do you notice? He's not engaging with the adult, right, over where they're pointing. He's actually almost looking at the finger like it's an object, right? And so that's going to sort of, make it challenging for him to learn from what the adult is trying to show him. And so that's an example of a more impaired social communication behavior. This is one more example I'll show you. In the interest of time, I have tons of videos, and actually the Autism Speaks website has loads and loads of these kinds of videos. And I'll give you some resources at the end for some good video libraries. So this is, again, a typically developing 3-year-old. Again, this is just a free play as part of actually a well-known standardized assessment for autism called the ADOS. So this is the examiner, and this is the child, and there's a parent in the background as well.
Is it loud? I heard that. It is loud. That's hurt my ears. It hurt your ears? That is loud. that higher in the ears, Mommy? Not really. It's a loud click, though.
So I just showed you half that clip, but what you see is that he's playing with this toy that, and it's funny, I always joke that that toy bothers me in that testing kit, because it is like, who would not get stuck on it? You like press a button, things pop up. So kids often get stuck on it, but what he's doing is he's interested in it, but he's sharing his enjoyment with the examiner and with his mom, right? He said at the end, does that hurt your ears, Mommy? Because it's loud when it opens, right? And so he's showing in that, his expressiveness, like he looks up with surprise when it pops open. So he's sharing this experience, and that's all. I mean, he has a nice language, but say I put this on mute, you would still see the really nice social communication that he's showing, right? And I think that's really key, especially when I'll mention in our next segment for a couple of minutes about what we're looking for in early infancy, right? When we're looking for early, maybe red flag behaviors. So this is an example of a child similar age who does have an autism diagnosis. Same toy.
Luke. Luke. Can you get him to look at you? Papa's Luke. Luke, look at Mama.
He's pretty much a gold medalist in not looking at these people.
It keeps going. It's like buffering. I want to see if it keeps going because I want to.
Hey, Luke, look at Mama. Look, Mama's phone. Oh, yes.
So there again, what you see is he's very fixated on the object, but there he's really not able to disengage. He's kind of stuck on it, right? And mom's trying to call his name. He's not calling. And then finally a sound is played. It happens to be a fake, cell phone. And he then, responds. So again, you can see the difference there, right? In terms of how he is, even though he's playing and both kids are really playing and fixated, how the difference in level of engagement and social communication with those around them. Okay, so those are the kinds of things we're looking for when we're making autism diagnosis. So the question we often get is like, well, when can you diagnose autism? And so what we know in this country is that ASD is usually diagnosed between 3 and 7 years of age. However, what we know is that parents will, articulate concerns about their child as early as the second year of life, sometimes even earlier. And so clinically, we know that red flags might appear earlier. And so that's what we'll talk about in the next section. But I will just mention that because of this knowledge, we do not wait until 3 years to be even clinically in pediatrician's office screening kids. And if those of you who have children who are 15 months or 18 months, you probably have done an MCHAT, right? Which is just a basic autism screener in your pediatrician's office. We do that because we really care about parent concerns and we want to know if there are red flags. The questions we're asking are really around social communication skills, as well as some of those repetitive behaviors or restricted interests. So the question comes up then, well, how do we study early development in autism? How might we, if we want to identify robust early markers in infancy, so we can start interventions or start, at least following kids more closely, how do we do that? And so on the research end, there's many ways we can do that. I mean, you could argue, hey, we could just study the whole general population. All of you who have infants and everyone else could just be followed prospectively. But you can imagine what a tall order that is, especially when the rate of autism in our, the national rates vary a lot, and I won't get into, why that is, but just to say that, the rate's about 1% to 2% in the general population. So we have to study a lot of kids to be able to then say, oh, well, this is a predictor of autism. And it's really almost untenable to be able to do that. So what we do in our research studies is we leverage other groups that are considered at higher likelihood or higher risk for having an autism diagnosis. And the two groups that we study, and again, I'm not going to show you any data today, are infants who have older siblings with autism, what we call familial risk. The rate of autism in a younger sibling who has an older sibling with autism is somewhere around 15 to 20%. So it's a higher likelihood group that we can follow from early development. My group also studies a lot of very specific genetic conditions where the rate could be as high as 50% or 75%. And so we can do that. I make that pyramid because the higher you go in the pyramid, the smaller the sample, right? So genetic syndromes are rare. So they have a high prevalence, but they're all, they're spread out all over the country and, often not in areas where they can get to some of our centers for research. So it becomes a different kind of challenge. But again, what we do with this kind of research is try to generalize and say, hey, if we're seeing early markers early on, maybe then we can use those to inform how we're going to screen the general population. And so again, as you can imagine, we can do these studies prospectively. In fact, with the familial risk group, there's actually this huge international consortium called the Baby Sibs Research Consortium. You guys can go to the website if you're interested. Mirella and I are both very actively involved with that consortium. And it's basically all the different sites around the world that study familial risk infants or baby siblings. We call them Baby Sibs. And you can see a map of all the sites around the world. There's been all sorts of papers written from this group. And I'm going to summarize, tomes of data in one slide or two slides, because this is what's most relevant to all of you. Most of these studies have thus far, until folks like Mirella and I have gotten involved, focused on behavior, right? To ask, let's prospectively study infants and figure out what are the earliest behavioral signs of autism. And so here's what we have found. Okay, so as early as 6 months, and again, this is not 100% predictive. So I really, really caution, I don't want folks to read this and say, oh my goodness, my kid has a head lag, they're gonna have autism. There's no one predictor that is that definitive. So these are just, when we look at as big cohort studies, what are signs that, statistically, meaning when we do the math, predict an outcome, right? But it's not perfect by any means. So by 6 months of age, we do see that kids who develop autism have some early motor signs. They might be delayed in gaining motor skills, such as maybe not sitting up on time, having some, delay or some differences in their overall motor tone, which might affect things like their head control and other things. We see some basic delays in visual reception skills, like visual attention, visual tracking, and then definitely starting to see some reduced social attention. So they may not be as attentive to social inputs like faces the way they might be to non-social stimuli as early as 6 months. By 12 to 18 months, though, we see more robust signs. And those are really the things that, you might guess what those are based on the videos I showed you and how I talked to you about autism. The next slide gives more detail here, but we do see some reduced social attention and social communication skills at 12 to 18 months. And we start to see some repetitive behavior with objects. But importantly, we've not found reliable behavioral markers in that first year of life. We're just starting to see some trends there. But again, in that second year, there are some behaviors that we see. Let me give you more details here, and I'm happy to share these slides, right? So in that second year, what are those social skills that we might see delayed? So we might see lack of consistent eye contact, limited positive affect, like shared social smile, shared positive response to interactions, lack of shared interest or enjoyment. Remember the video I showed you of the joint attention and the kiddo who squeals and smiles? That's an example of that. Inconsistent response to name. We do like to see kids respond to their name, like turn to their name around 12 to 18 months. With regards to language or communication, lack of gesture use, unusual speech or prosody. So as they're gaining words, they may not sound the way they would in normal conversation or the way it might in a typically developing child. And then less specific might be just actual delays in the acquisition of language, but that's not been shown to be a robust predictor. We might see repetitive play or some repetitive motor behaviors, but I say the word caution there because there are normal or typical stereotypies or repetitive behaviors that little kiddos do. And then anytime we see a loss of skills, I don't mean tiny dips in development. I mean, a child has a robust repertoire of skills that they completely lose. That's a huge red flag for me as a neurologist, especially. And those are kids that we would want to follow more closely. Okay, I'm almost done. I'm at 20 minutes, I think, or 19 minutes. Once we make a diagnosis, what do we recommend? Okay, and this is, again, a really just general slide for you guys. We recommend behavioral intervention. That's really the gold standard right now. We have no medications that are that target the core symptoms of autism. So we recommend intensive treatments that are both behavioral interventions outside of the home, as well as ones within the school system. And I'll just sort of leave it at that, but it's really around behavioral interventions that target those various behaviors. What I will say, and this kind of segues to the research piece that Mirella will talk about a little bit, is that what we know through lots and lots of different studies, some of which we've done at UCLA, some of which have been done at other networks, is that even though these behaviors emerge, maybe at 6 months, maybe definitely in the second year of life, based on beautiful studies in autism genetics, in imaging, in EEG, and lots of different tools, we know that there's probably very likely changes in the brain, especially the way the brain is kind of wired, much earlier than when we see those behavioral changes. I want to make a really important point about this. The brain is a complex, very dynamic system that's constantly responding to environmental inputs. So these brain changes we see are not static, right? Our brain is constantly wiring and rewiring based on environmental inputs. So this is not a static process, but we do know based on lots of different kinds of studies that the brain is wired differently in children with autism, and that we can see these signs emerge as early as, in Mirella's case, 6 weeks of age with imaging, in my case, 3 months of age with the EEG measures that we use. And so we know that these brain changes occur early. Okay, so why is that important? Well, we've been doing research that asks this, I think, important question, which is, could we identify changes in the brain even before we see changes in behavior? Why is that important? Not because we think that we can, again, predict on a 1-to-1 scale, but that if we can start identifying what are those robust differences, we can improve how early we identify kids who might be at even higher likelihood of getting an autism diagnosis, so we can start interventions really early. Because look, with all this research, our goal is not to watch development unfold, right? We want to intervene as early as we can. So if we can identify brain changes before behavioral changes, we might be able to start interventions even earlier and maybe even change the way the brain is wired. So that's really good, the goal. And that's what this baby BIBS study, BIBS stands for Brain Imaging and Behavior Study. At UCLA, we love acronyms and we love logos. So this is one of them. And so in our study, we actually see babies who are considered at risk. That may be because they have an older sibling, they may have a genetic syndrome, they may be a graduate from the NICU, variety of different risk factors. And we see them as early as 6 weeks of age. And we do imaging with MRI. We use electroencephalography or EEG to look at brainwave activity. And we're really asking, can we find differences? And we've actually published some data from this already that I won't go into today, but this is sort of the work we're doing. And it's this study that we're hoping to partner with Nanit on to start also looking at sleep. Okay, so my last 2 minutes, I just want to mention this because I know it's going to be asked. You're probably asking, like, why the heck are we talking about this when we're, working with a group that's done this beautiful work in sleep monitoring? Well, as a neurologist, I'll say that insomnia is like the #1 co-occurring condition that I manage in my patients with autism. So it is an issue, but I just want to reinforce for the 50th time that just because a child has sleep issues does not mean they have autism, and babies have all sorts of different sleep patterns. So if your baby's not a great sleeper, it doesn't mean they're going to have autism. There are no robust predictors of sleep issues with autism, although it's an interesting question to ask. But in children with autism, we know that sleep difficulties are really common. We see insomnia in up to 80% of kids. And the pattern we see is that they have difficulty falling asleep. They wake up a bunch in the middle of the night, and then sometimes they wake up really early. So they just don't sleep enough, basically, as you can see based on that. And there's been many, many experts around the world that have put their heads together to develop guidelines on how to diagnose and manage. And I'm not going to go into that today. I'm just going to say that there's some really good toolkits available on how to manage behaviorally, how to manage sleep challenges in autism. This was a paper that came out a couple of years ago from the American Academy of Neurology. If you're on this webinar and you have a child with autism, I highly recommend the Autism Speaks toolkit. And I have the link here. They have a few different toolkits on sleep management for children with autism, but the gold standard treatment is behavioral modification, which I know is hard, but with expert clinicians, you can actually work with them to really think about things like, improving the nighttime routine, keeping a really good schedule, having positive reinforcers that help promote the child to sleep on their own at night, and try to stay asleep and not get into mom and dad's bed. Some key tips that I give parents, and the first point is the biggest one, is that a lot of our kids, especially kids with autism, are on their screens at night because it's often the one thing that's really soothing for them. And we actually know that screen light exposure impairs the brain's response. The brain doesn't produce the neurohormones that need to be produced to tell the brain it's time to go to sleep if you're exposed to this kind of screen. I say this is the biggest hypocrite on this because I am on my screen before I go to bed also. So for all of you parents who are feeling bad, don't feel bad. I do it too. But for a child who's more vulnerable to insomnia, like a child with autism, this is even more important. So I always tell parents, try to avoid light exposure like iPads and other things at night. Exercise is really important. Stick to a really good sleep routine, positive reinforcement for healthy sleep, and then avoid eating and drinking a lot before bed because that'll make them get up in the middle of the night to use the restroom. And so with that, I'll just...
Can I just jump in there for a second? Can I just ask you, you're talking about avoiding light exposure. I know we know that, you know, a lot of kids are using screen at nighttime, and particularly kids with autism. Can you give a little bit of guidance around sort of a bit of a timeline around how many, you know, how many minutes or hours before their, you know, their bedtime that you would like them off screens?
No, it's a great question. There was actually, I don't have the slide here, but there was a great study that actually just looked at, you know, differences in sleep, duration of sleep at night in kids with autism compared to typically developing kids. And it was just based on whether they had a computer or TV in their room.
Mm-hmm.
And they found differences. So the point being, we don't know. We just think any exposure is not great. But just because we have to be practical, what I tell my parents is 1 hour before bedtime. Try to avoid screens 1 hour before bedtime. So after, you know, if they want to be on their iPad and it's reinforcing, great. Have that be part of your routine, but have it be on the front end of your routine rather than the back end of your routine. So you do the screen, then you do bath time, then you do story, then you do whatever else needs to be done.
And I think that's really great, great guidance for typically developing children as well. So, you know.
Absolutely. And I think that, you know, I bring it up with the autism group because we think that they're probably more vulnerable to any little environmental stressors that would undermine healthy sleep. But I absolutely agree. And I tell all my, you know, parents and my friends actually as well about this again. And I say that just with the taking the grain of salt that we all as adults are, you know, I think, guilty of this as well. So it's good for us to remember this as well.
Totally.
So yeah, so I'll stop there and go ahead. I just, you know, this is, if you guys are interested in learning, if you live locally and are interested in our study, we also have an early intervention study that actually starts at 12 months for any child showing red flags. So if there's concerns from the parents' end or our end by 12 months or later, 12 to 36 months actually, they can be enrolled in an early intervention trial called Baby Bears as well.
And so for all the participants, we will send all of the information about the studies, Shafali, so that everyone has that information. If anyone's in the LA area and is interested in, you know, being part of these studies, we would be thrilled if you would want to enroll. I had a quick question for you before we move on. You talked a little bit about the difficulty of, you know, getting to a diagnosis, or, you know, that that it's not a simple, you know, blood test or any sort of simple sort of it's not really a simple test. It's based on, you know, behaviors. Can you tell us a little bit, do you have data around how long it typically takes to get a diagnosis from, say, the first time that people are, you know, bringing these red flags to their pediatricians?
Great question. And it depends, as you may imagine, significantly on where the family lives, unfortunately, how resourced they are, both from a parent standpoint and frankly, a family financial standpoint. And unfortunately, there's a lot of disparities based on race and ethnicity as well. And I don't have that slide here, but lots of studies showing that African-American families are diagnosed later, families who live in rural areas are diagnosed later, and families of lower socioeconomic status are diagnosed later. So it depends, honestly. And so, you know, it should not take a long time. So what should happen, I'll tell you the ideal pipeline. A parent has a concern. They call early interventions. In the first 3 years of life, a child is eligible for early intervention through the state. Okay, so in California, we call it the regional center. It's called different things in different areas. But in the first 3 years of life in the US, you are eligible for early intervention services. You just need to get evaluated. And a clinician does not have to actually refer a family to early intervention. So if a parent has concerns, they can go straight to early intervention. Sometimes it helps to have a clinician corroborate it. But once that happens, the early intervention team within a few weeks, and there's actually different guidelines based on state as to how long that should take. But within a month, there should be an evaluation that's performed. That evaluation should then lead to recommendations on what intervention the child should receive. Now, does that lead to a definitive diagnosis? Always no, but our goal is at least let's start services. And then you can get referred to an expert clinician to, you know, to conduct the full evaluation.
Amazing. Great. And we will share your slides too, if that's okay with everyone who came, so that they have this list of resources. Would be fabulous.
Great. Yeah, go ahead. Yeah, do you me to stop sharing the screen now? Mirella?
Yeah, well, yes, that would be great.
I'm still sharing a screen, I think. Hang on. There we go.
So thanks so much for going over that amazing presentation, Shafali. It was really fabulous. So that it really segues beautifully into, talking to Mirella about, the work the research work that you are doing. So
Yes.
Mirella, I'd love you to tell us a little bit about your work.
Thank you. I will be short because I noticed that there are quite a number of questions. I've tried to answer a few on the fly, but I want to make sure that there is ample time for you guys to ask questions and for Shafali and I to try and address them all. I want to second, first of all, before I go into what we are doing and the overarching goals, the fact that we are all guilty, right, of being plugged in front of a computer or an iPad or not, as Shafali pointed out, late at night. And I just want to encourage everybody to, at the very least, do whatever we can to mitigate the effects that some of the UV light would have on our production of melatonin. And most iPhone computers and iPad, you can regulate the color screen, the light of the light that it's emitted. So everybody should be familiar. I hope that you guys are, and that it's at least a first step toward mitigating the effect that being plugged in until before you go to bed would have. But I think Shafali has already touched base and presented our strategy. In a way, the overarching goal, right, is to be able to develop early markers so that we can intervene way earlier than typically is done. If you think about, I think most people are very familiar with the concept of plasticity, neuroplasticity. It's a concept we know from, people have heard. If you suffer a stroke or a car accident affecting your brain, the younger you are, the most likely, the better your recovery, right? And so the first 3 years of life are a dramatic period of brain development. And the first year, even more so than the first 3 months. So in a way, we are missing by waiting for the traditional waiting for children to be diagnosed around the traditional age of 3 to even 7 years of age. We're missing out on that most important early period of critical and robust neuroplasticity. So the goal is to try and find early signs that we can detect, not behaviorally, by looking at brain-based marker. Shafali has already alluded to the fact that we do see, and parents do, and we as researchers do see in the labs, red flags in the second year of life, 12 months and older. But in the first year of life, we really don't have any robust way to predict which children will later go on to receive a diagnosis. So that's where our study has typically has focused on. And you saw a trajectory where we start as early as 6 weeks with MRIs, which may be scary for some of you who may have received an MRI and for clinical purposes, and you think like, oh my goodness, I mean, how can you do that in babies? Because it was so loud and annoying. But the beautiful thing is that we have ways to really protect the children's ears, and we are actually capitalizing on natural sleep. So there is no sedation, nothing of the kind. It's very, very safe. And we are able to get beautiful images of babies' brains as they develop. And we are not only able to look at how their brain looks like in terms of structural developments, how it grows, but also we are able to look at how the brain connections between different parts of the brain develop to support the emergence of more complex behavior. And interestingly, we can also see brain function, because even when babies are asleep, we can still present them with some auditory input, say speech, or recorded perhaps from their mothers as well as from other folks, that and compare that brain responses to other type of known social signals. So why are we doing this? It's clear. We want to be able to predict which children would benefit from very early interventions. How we're going about it is something that Shafali has already showed you. We are going about it both by measuring electrical recorded from the scalps where babies are awake and they're coming in for the lab, and by using neuroimaging tools. How do we go about from those measures to making prediction? Can we do that? I mean, a lot of the time we're asked, if I bring in my child in and that you put them in the scanner, you get an MRI, will you be able to tell me what the chances are that my child will develop autism? And I must say that we're not quite there yet. However, there have been published studies in relatively, well, they still need to be replicated, but we have identified some brain-based marker that from data collected at 6 months allowed to predict which baby we're going to develop an autism diagnosis 2 years down the road. So we are really in the midst of and I'm using the royal we as scientists, to really replicate this initial findings. And at UCLA, we are particularly interested in pushing the envelope even further and look at the first 6 months of life when it comes to MRI. We mentioned we bring them in as early as 6 weeks, and we have found quite a number of differences when comparing babies that are at high familial risk for autism versus the babies that do not have a family history of autism. That is not to say that we can predict yet from that. We have ongoing studies that we need to have a larger sample in order to be able then ultimately to compare and assess the the ability for these early differences to predict a later outcome. But we're not just using any single one brain measure. We want to really put all together the evidence that we get from behavioral assessment, EEG measure, and MRI measure to arrive at a better classification system, if you will. But more importantly, we hope that this research will not only allow us ultimately eventually to predict which child may benefit most from intervention, but also what type of intervention they may be most beneficial for any particular child. As Shafali already pointed out, that autism is characterized by tremendous heterogeneity, right? So many babies and children and toddlers present different symptoms. And so Shafali has also pointed out that the causes may be quite different from one child to another. So the idea that one single type of intervention would be beneficial across the board for all children that receive a diagnosis may prove to be misguided. And so we hope that we will ultimately be able to reach the goals of precision medicine and be able to develop a very tailored and targeted intervention, given what we know may be the particular problems, not just at the behavioral level, but the issues in if you will, in terms of atypicalities in how the brain processes the information in their environment. Shafali alluded to the fact that we, as our group, have done quite a bit of work on one particular aspect of symptoms that have more recently gain more attention, and we're talking about sensory processing atypicalities. So those hyper responsiveness to very stimulating environment, loud noises and the lights and all the kind of it can be quite disruptive in the life of a child with autism and their families. And as it turns out, they may be perhaps one of the earliest things that we could detect early on. It's not at the brain level. Before a child can do things like, covering up their ears or squinting their eyes when loud noises happen or there is a visual stimulation in the environment, when they're really, really young, they're not going to be able to tell us how they feel about the stimulation that surrounds them, but their brain responses might. And we feel this is very important because the scientists have come around to the understanding that the core symptoms of autism that Shafali talked about, and primarily the social communication and social interaction deficit, may actually result from more basic disruptions in more basic mechanism like that involve sensory processing and also motor atypicalities. So those may eventually cascade or cause disruption in social development because a baby may not be able to learn enough from other human being in their social, and that obviously that will cascade into social impairment. So why are we partnering with Nanit? Well, because it turns out that there is a very strong relationship between sensory processing atypicalities in autism and sleep problems in autism. Sleep problems in autism are quite pervasive. And we do know that they do relate to the sensory processing atypicalities. And we also know that parents of children who later get a diagnosis, sleep issues is one of the things that they report consistently, that they flag with their pediatrician. Now, of course, all parents of any infants that I know have have had sleep issues, because we as parents, we tend to be sleep deprived because babies obviously do need to wake up for nursing and for to be changed and all of that. So I don't want any parents here to be worried, oh, my child must be at increased risk for autism because they have a baby that, unlike maybe the baby of another friends of theirs or a prior child, has more difficulty falling asleep or staying asleep through the night. That's something obviously that develops in the first year of life, and there is tremendous heterogeneity and variability in typical and atypical development. But we're basically now partnering with Nanit because the technology that they have created will allow us to have state-of-the-art, very objective measures of the quality of an infant's sleep. Parents are very good at reporting back on how long it takes for the babies to fall asleep, and also to estimate how much time their babies sleep over the course of a night. But what we can do with the information that the Nanit baby monitor does is to really assess not just the duration, but also an additional set of parameters that can be quite informative. And I'm talking about the fact that even when a baby may not wake up and parents may not be aware, they may not cry, so parents may not be aware that how many times their baby may actually be waking up in the middle of the night, nor they can detect necessarily how restless their sleep may be. And we have through this the information that Nanit records, we are able to actually estimate some of these important parameters. I don't know how many of you might have heard about fragmented sleep. That's not as good as sleeping through and go through the whole phases of sleep, and some of which are more important for learning and so it's really an exciting time for us to be able to add this additional and very important piece to our research. And we are very much looking forward to what the findings are that we are going to be able to collect. I don't know.
I'll just jump in there for a second, Mirella, and add on to that, and most of the audience probably may not know that typically in a sleep, if we're in a sleep research setting, we would typically use a device called an actigraph that's usually only used, that you put on the baby's ankle, and you would use it for perhaps a week, perhaps 2 weeks at a time. And it's not fun for the baby to have on necessarily, and it's only really a short period of time that we're able to collect the data. So with the camera, with the Nanit camera, we're able to really give UCLA this nice longitudinal data over a really long period of time. So hopefully we will get, some really nice, rich data for them to analyze. So we're super excited about that.
Yeah.
And I just wanted to, I know that we're getting close to coming up for time, and so I really would love to move on to a couple of the questions. And I see, Shafali, that you jumped in and talked about a previously controversial issue, but I would love you to talk a little bit about vaccine.
But the vaccine, I said I would try to tackle verbal without typing all the complexities of it. But yeah, a lot of you are asking good questions that I'm trying to answer. I just want to give sort of a blanket answer to some of the questions, which are, folks are asking a lot about their infants, right? And, they're manifesting certain behaviors. Should they be worried? And generally, my suggestion always is your child best. And even if that means if you're a new parent and you haven't actually watched development unfold, or you are a new parent, you have, either way, I think, we always as clinicians take parent concerns seriously. Now, again, there may be times that you have concerns and you go to the pediatrician and they say, I'm not concerned. So, if you want to go still seek out early intervention, you can, but I'm telling you that based on the hundreds of thousands of kids I've seen, I think your child is fine, but that's helpful. It's an important conversation to have. So I just really encourage all of you, some of the behaviors that you're describing don't sound concerning to me, but I would absolutely need to see the infant in the context of the other behaviors and other things. And so I think it's completely appropriate to go to your pediatrician to ask, and I'll say anecdotally, like I have two kids who are older now, 11 and 13, and my older one who, is perfectly fine developmentally and doing great doing great now, he's in 8th grade. He was a late walker, partly because he was a really big kid. And so at 15 months, he wasn't walking. And I was completely convinced that he had global developmental delay and that he needed intervention. And I was ready to go take him to the physical therapist. And I went to my pediatrician first. And he said, look, put it in the context of everything else. Like he's otherwise doing great developmentally. I'm not worried. If you want to go seek out early intervention, you can. But just having that dialogue helped me enough. And then he walked a few weeks later and it was okay. But I was convinced that there were all sorts of delays. And he helped me put it into a context, especially because I was also a sleep deprived parent and didn't probably have the best, I wasn't being objective by any means. So I think that, but parent concerns are important. And we actually have a paper that's about to come out where we actually looked at parent concerns in our infant SIB study. And we found that parents of kids who developed autism did not have concerns that were specific to autism by any means, but as a group, their parents were describing some general concerns. And our take home was that we as clinicians should pay attention. And even if it means we just follow a little bit more closely, that's worth it. That I think can be really helpful. Okay, so I got asked a lot of vaccine questions, or not a lot, at least a couple.
Yeah, I would love you to address it.
I'm going to try to be brief about this because I have very strong feelings about it, actually. But I'll just say that, autism, and you heard me say this earlier, sort of the behavioral signs of autism, unfortunately, unfold in the second year of life. And that happens to be in the time when we're administering a lot of these vaccines. And so it's tricky, right? Because I can't tell you the number of patients I've seen who say, well, hey, they received the MMR, they received whatever, the DTaP or whatever it was, at 15 months or 18 months. And shortly thereafter, I started noticing that he or she was not making eye contact, was not, saying words the way they were supposed to be. And it turns out that those are when there have been studies that have looked prospectively, at children who develop autism, it's not that there is this really dramatic regression around that time. What we actually are finding is that there were probably some subtle delays early on, and they just became more magnified when those behaviors didn't occur when they were supposed to. So we become kind of, attuned to it at those times. And I think for many parents, and it again makes complete sense, you might even be even more attuned to it when your kid's getting vaccines. So that's one sort of, thing I would say. The second thing I would say is that in terms of how do you actually scientifically answer the question about do vaccines cause autism? You cannot in any ethical world not provide children with vaccines to determine if the rates are better, right? Because vaccines save lives. So what people have done, and these were studies sponsored by the World Health Organization, the Center for Disease Control, all kinds of different groups, they were able to look at places around the world, mostly less so in the US, but in Japan, in certain parts of Europe, where there were vaccine, programs that then fell away because of funding, public funding. And they were able to look at vaccine rates, pre and post vaccines. And it turns out that there was no difference. Right, that the vaccine rate or the autism rate, continued to increase or stay stable even when vaccines were gone compared to when there were vaccines. So, and so based on those data, there was actually a statement that was put out by the WHO and the CDC and others that said, we cannot prove any causal relationship between vaccines and autism. So they didn't say, we definitively say vaccines don't cause autism, but what we say is we have no evidence to say that there's any causal link. And so I think so based on that, I think that we really, and then the last thing I'll say is that there's, from a biological standpoint, even if you're worried about the mercury in some of the vaccines, which now actually there isn't even mercury in the vaccines, the dosage that you're getting and the impact that could potentially have on brain function is so minuscule that we even think from a neurobiological, neurophysiological standpoint, it's very unlikely to be causative. So based on all that, we as a field really strongly, support the administration of vaccines. And I always tell my patients, like I have 2 boys. Boys have a higher rate of autism than girls, 2 boys that I vaccinated on time. And if I was truly concerned, even like an inkling that there was a cause I wouldn't have done that.
Can you tell us a little, just you alluded to having boys. Can you tell us a little more about why we think boys are more likely to develop?
Mirella, because she's the principal investigator of a huge trial. So it's twofold, and I'll say one is biology. So there are some protective factors in girls based on that second X chromosome and probably other, even just like genetic background pieces that actually do make girls more social. I'll just say there's more social protective factors in girls. So there is that, but it's also, we think there is probably some sort of diagnostic bias. It doesn't account for, it's not like there's so many girls hidden with autism, but girls tend to present differently. They tend to present less overtly. So there's more anxiety, more social withdrawal. They may have some milder symptoms, so they may not be picked up as earlier. So there are some sort of clinical differences in girls that may lead to an underdiagnosis. We do actually really think that there's a biological difference in girls versus boys that lead to them being a bit protected from some of the neurodevelopmental disabilities. Because we see a 4-to-1 in ADHD also, and in global developmental delay.
Interesting.
I don't know, Mirella, if you want to mention Gendar.
Well, we are we're one of the 4 sites that has engaged in a large-scale study where the ultimate goal was to compare girls with autism to boys with autism in terms of brain-based measure, because most of the prior work done at any institution was just not sampled enough to begin to address this question. And we definitely have found a number of differences. And so some of the responsibility, for instance, of this circuit in the brain, the reward circuits, which is kind of like that area of the brain that lets up, say that you're a mother, you're looking at a picture of your brain, or if you're a drug addict and you're thinking about, drugs, or if you are very thirsty and you see a picture of a nice drink. And so anyway, this is a circuit that has been found to be less responsive to social stimuli in individuals with autism in a number of neuroimaging studies, but those studies were done primarily in boys because, again, they're much more easy to enroll in studies because they get diagnosed more often. And when we have done the same studies in boys and girls, we found that there wasn't really less responsivity in the circuits in girls with autism. So there you have it just really stress the importance of having a fair representation of girls when looking on autism, because together with all of the other variables that we have talked about that can impact how a disorder is manifested, it can also be an important variable to keep in mind when we are targeting, when we are designing targeted intervention. If we know that there isn't this lack of responses in reward circuits, and so that they show more social motivation, more motivation to engage with others, and that's rewarding, we can use that information when we are intervening in girls as opposed to boys. So it's very important research that it's being done, but it's complicated. I'm sorry to say, it's always the case. There isn't one single mechanism that can account for this divergent profiles.
Now, and I have another question. So if you're, so you were saying, Shafali, that you are, you're the, a lot of your work is looking at these, these baby SIBs. If you do have a family history of autism, how do you recommend what do you recommend that families do? Are you recommending that do they need to be more vigilant? Do they need to be doing anything differently than if they had no family history?
No, it's a great question. And there aren't formal guidelines on this, but I'd say we as a group definitely suggest in this early concerns paper that will be out soon, really we talk about this here, which is that I think clinicians need to monitor those kiddos more closely. I think that that's just, and I think that, again, it's not the rate of autism diagnosis in that group is not 100%, it's 15-ish%, right? So it still means the majority of those children will not have developmental challenges, but we actually are finding that even if they don't have an autism diagnosis, there are some kids who have older SIBs with autism who might have other developmental challenges that might be more subtle, but things like a little bit of speech delay or milder social challenges that don't meet full criteria for autism, but might have, or maybe even other developmental delays. So my recommendation is, if you have a child with autism and have an infant, just remind your pediatrician that, your infant should just be monitored a little bit more closely, meaning they should listen to your concerns. And if you as a caregiver have concerns, again, I think there's no harm in, if you're comfortable with it, in seeking out, an assessment through early intervention. The flip side to that is that, all those things all these, experiences can be stressful for parents. And what we don't want parents to have to turn into, clinicians for their infants. And we want you to enjoy your infant and not worry all the time that something bad is going to happen down the road, right? Because most infants do great, and there's lots of variability in development, but they actually have really, great outcomes.
Yep.
So, yeah, so I think it's a tricky balance, and I think it depends on how comfortable, you as a caregiver feel.
Great. Fantastic. Okay. I am so grateful to both of you for your time and your wisdom and your expertise. And I know that, and Shafali, I see that you answered a lot of questions in the chat.
I got through about half, and then they kept coming, so I stopped typing. I'm sorry.
So thank you so much for that.
Questions if you want me to over email or something, if there's.
Great, thank you. And we will be sending your slides when we get a chance to all of the participants, and you can contact us if you have any other questions or concerns. But we're excited about our collaboration and excited about doing more work together. And I'm so happy that everybody could join us today, and I certainly learned a lot, and I'm sure that everybody else did. So, and we've got a last. Oh, I'm being told that I need to share the results. I see that we have a lot of people from everywhere. Most of you are Nanit users, which is fantastic, and a lot of you have very small babies, which is great. And so we're really happy that you could join us today. So thank you so much for that. Thanks so much to everybody. I will be signing off now. And Mirella, Shafali, thank you so much. We'll be in touch. Bye.